Hi, everybody that's joining us. We're going to get started in just a couple minutes here. Thanks so much. Okay, get started. Great. Looks like we have more people joining us. So just be a couple more minutes here. See if Facebook will work for us. All right. Okay, we got it right here. So we're going live on Facebook, and then we should be able to get started. So to make sure that's good for the people watching there. Okay, great. So we're on Facebook now. Let's start my video. Great. Okay, all that technical stuff. All right. So bring this up. Okay, great. Can everyone see my screen with the introductions? Perfect. Okay, great. So we'll get started. Grab this here. Thank you so much, everyone, for joining us for the Fox Cities Book Festival virtually. We're really excited that we can come together like this and have so many great events throughout the end of the week. So we got this here. Okay. So we would like to thank our partners. We couldn't do this without the support of so many wonderful people in the community in the Fox Cities. It's really a collaborative effort between public libraries, school districts, foundations, bookstores, and community members. So we appreciate the support, and it's something we couldn't do without everybody's help. Okay. So we're able to provide these great events without financial barriers. The events are free to attend, thanks to all of our generous donors. We appreciate them so much. We'd like to take a moment to just recognize them and say thank you. If you think supporting local writers, building an engaged community, and introducing students to authors by bringing free educational events is important, we would love if you would be able to do a donation or share our Facebook page on your page, or just tell a friend about us, our events. We would appreciate it. Also, because of just the digital event here, we ask that everybody conducts themselves in a safe and harassment-free manner. Any harassment of attendees, presenters, or volunteers in the chat comments will not be tolerated. So we just ask that everybody attends with kindness. This. Okay, all right, great. So now the moment that we've been waiting for here, we have Dr. Adam Stern joining us today. We're so excited. Something I can tell about here. I've got lots of screens open, so. So we've got Dr. Adam Stern here today. He is a psychiatrist at Beth Israel Deaconess Medical Center and an assistant professor of psychiatry at Harvard Medical School. In 2018, he was diagnosed with a life-threatening cancer, and he's been written extensively about his experience as a physician and also as a patient. He's written for the New York Times, the Boston Globe, New England Journal of Medicine, and the Journal of American Medical Association. So we're super excited to have him here. So today he's going to be sharing some information about his from his training as a psychiatrist to living with cancer. He wrote Committing and Moving Forward No Matter What. And Dr. Stern will speak about committing and moving forward in a way that aligns with our values no matter what. So please join me in giving Dr. Adam Stern a very warm welcome. Thank you.
Thank you so much.
And really my screen here. There we go. Sorry, now you're on.
Great, great. I'm really happy to be joining this event. Fox Cities was the very first group that invited me to speak about the book, even before it was out formally, and I'm just really honored, and it's a real pleasure to be able to talk to this group. I did write this book, and I'm going to try to structure today a little bit unusually. I'm going to read a bit from the book, and then I'm going to tell you my story and give it a little bit of context. And then I'm going to pick up the book again and try to make even greater sense out of one of the storylines coming from the context of where I was writing it from. And I'd love to throw it to questions at the end. I'm an open book. My life is an open book, and so I'm happy to answer anything that people may wonder about. Just a few quick content warnings. I am living with cancer, and so I'm going to be talking about that. I'm going to be talking about things like death and dying, and that can be very triggering for some people, and I want you to be aware of that up front. And if you need to step away, then please do so. And also, one of the characters in the book that I'll be reading uses very salty language, and I'm not going to censor that. I'm just going to read it as is. But if that kind of thing offends you, feel free to please step away as well. All right, so without further ado, I'm going to talk a little bit about what this book is all about, and then I'm going to read a section from it. The book, I started writing it just about 2 years ago, and the book is really trying to be the first entertaining, engaging, interesting book about the topic of how do you take someone who is a newly minted medical school graduate and transform them into this idea that we all sort of carry with us about what is a psychiatrist, and in particular, a psychiatrist within academia, within sort of this ridiculous ivory tower that we sometimes work in the field. And that was my goal. And one of the ways that I wanted to do that was to really convey the story through my own eyes, my own experience going through the training, and also by telling the story about the connections that I made over time with both my colleagues, my mentors, but also the patients that I encountered. And I've taken a lot of liberties in terms of making sure that I've protected privacy of anyone that I'm talking about. So details have been changed, names, dates, locations, and I've also created some character composites where some patients might be represented in the book as one individual, but in real life, they were multiple individuals. And so I like to say that up front as well. So I'm being very forthright about what I did to protect everyone's privacy in the book. And so without further ado, let me jump in. For anyone who has the book, this is chapter 18, page 145 of the hardcover edition. Charlie was a patient already in psychiatric treatment, but he was new to me, and I realized that neither of us wanted to be engaged in this evaluation. His choice of words had taken the decision out of our hands, though, as he had expressed what's known as conditional suicidal ideation, saying he would end his own life if the surgery revealed cancer, and it had, which meant that when he came to, he was met by a one-to-one sitter and a pink paper denoting that he was not free to leave, even against medical advice. Before his operation, he had told one of the attending psychiatrists that he didn't think he had the stomach to die of cancer and would rather end it all while he was still able to. I assumed that the attending psychiatrist, who had known the patient for years, was home with her family, but she had left a note telling the surgical team that if the biopsy tissue revealed cancer, he should be emergently evaluated. I was paged to come see Charlie because I was the second-year resident on call. Even though I had never met this man, and even though I had little formal training in doing psychiatric consults on the medical wards at that point, it fell upon me to both figure out if he was truly a danger to himself and see if I could possibly offer some kind of therapeutic encounter. I would settle for doing only the former if that's all I could muster. After the interview, I was supposed to present the case to a senior resident by phone and the attending on call at home. This was a delicate dance among psychiatry residents, their supervisors, and our patients. Even when we made decisions in the room with a patient, we often had to clear them with a higher authority, so we tried not to make any promises in real time, lest we reveal ourselves to be the impotent underlings that we were. In this case, it also happened to be the middle of the night by the time he perked up enough to talk. "And who the hell are you now? First I've got this lady," he said, motioning to the one-to-one sitter, "and now some Doogie Howser MD comes in. What do you want, Doogie?" "I'm Adam Stern, Dr. Stern." "Okay, Adam Stern, Dr. Stern, why are you here?" "Your surgical team asked me to come talk with you." "You're not part of my surgical team?" I shook my head. "Then what fucking team are you from?" "Psychiatry." "Oh, for fuck's sake, get the fuck out of here." "I can't do that. I've been asked to assess you." "Assess me? Assess this," he said, grabbing his crotch. "I know you've had a difficult day. I don't want to take up any more time or energy than necessary, but I do need to evaluate you." "Why is that?" "Well, before you went under, you told your psychiatrist, Dr. Glidden, I think." "You think?" "Yeah, it was Glidden. You told her that if it was cancer, you would end your own life." A somber expression fell over his face, and immediately I knew that no one had told him yet. For fuck's sake, indeed, I thought. It is. It's cancer? Damn. I'm not surprised. All the signs were there. He began to sob into his hands. They were heavy, deep, almost visceral wails, the likes of which I'd never heard before. I looked over to one, I looked over to the one-to-one sitter as though she would know what to do, but she had her face in a newspaper. I felt the urge to put a hand on his shoulder, or even hold him in my arms, but something held me back. Psychiatry is strange about physical contact with patients, in many cases for good reason. Even when common sense and an empathic stance dictate that a hand should be placed on a patient, residents are trained to be wary and think twice. "I'm so sorry," I said, quietly, almost whispering. He continued bellowing without relief. Finally, I overcame my programming and put a hand on his shoulder. Charlie was a big man in his 60s. He reminded me of my father, and it felt out of character, but still right to be consoling him in this way. With the weight of my hand on his shoulder, he stopped crying, momentarily pulled back, and then leaned into it. He looked up at me. "Thank you. I'm okay now." I leaned back in my chair and waited for him to speak. "Cancer. What a clusterfuck. My wife is going to kill me. She always told me to take better care of myself, drink less, exercise more. I just never really thought it would happen to me. Do you have any sense of the prognosis? I assume not, since no one's talked with you yet." "Well, no, but also there aren't a lot of good liver cancers as I understand it." "That's fair. Let me ask you something. What's the most important thing to you right now?" "How do you mean?" "Well, what we know is that you have liver cancer, and we don't know much else. That part is out of our control, though. I'd like to think with you about factors that may be under our control." "Like what?" he asked. "Living as long as possible with a high quality of life, preventing suffering, making sure that your family's taken care of, those kinds of things. I was really out of my depth, but it seemed like we were connecting. He talked about trips that he and his wife had put off for years, that maybe they would finally go on together. He spoke about living long enough to see his son get married. It sounds like you have a lot to live for. He nodded. That comment you made to Dr. Glidden, I started. Forget it, he said. No, I can't forget it. My job is to take it seriously. You have good reason to feel that way. I don't want to minimize that, but I do need to know if you're safe to be on your own right now. Today I'm safe. I won't do anything yet. I'd been taught that this kind of contracting for safety is generally insufficient in a psychiatric risk assessment. He had a number of major risk factors for suicide in the context of his new diagnosis, including that his age was over 60 and he was a male. But my gut told me he wasn't going to act on the comment he had made, and that was also supported by his marital status and his being future-oriented. I confirmed there were no guns in the home, though a simple rope can be just as lethal. He had no family history of suicide, which is a powerful factor in many cases. Are you going to send me to the loony bin? I don't think you belong there, I said. What do you think? He shook his head. I needed one more scrap, one more little thing that would put my decision to let him off suicide watch on more solid ground. I have to do some work here tomorrow morning. I should finish by about noon. Can I come back and see you before I head home? I'd like that. It wasn't in the textbook, but his willingness to acknowledge that he would be around the next day and allow me to visit made me feel more secure. Good, I'll see you then. But I had forgotten one of the cardinal rules of overnight consults, which was to never promise anything before speaking to the attending. Tony Strand, our psychopharm teacher, was on that night. I presented the case and tried to convey all the points working in favor of lifting the suicide precautions. It's a tough call. I don't feel good about it, he said. Let's keep him on overnight. Let Glidden comment in the morning. I think that's really going to throw this guy for a loop. I'm not sure if he'll ever trust another psychiatrist again, I said. For tonight, better safe than sorry. Good night. He hung up, and it was my job to return to Charlie's room and explain that his one-to-one sitter would be staying at least overnight. Who the fuck does that guy think he is? It's my fault. I shouldn't have said anything until I knew for sure that he would be able to take down the precautions. He scoffed. I'll still see you tomorrow, right? I asked. He nodded. Okay, try to get some rest between now and then. I exited the room with my shoulders slumped and made my way down the hall to the elevators. It was almost 3 a.m. and remarkably, I was caught up with work. I'm going to skip forward now just to the next point at which I speak to Charlie. And that is on page 153. About midway through, I coasted through my morning sign out and rounded on a few patients up on 4 South before circling back to check in on Charlie. I rode up the elevator, still glowing from my encounter with Jessie, when a woman with very tired eyes introduced herself to me. I'm Charlie's wife. You're the shrink? Oh, yeah, I'm the shrink, I guess. You guess? Did you talk to my husband Charlie last night or not? Yes, yeah, that was me, I stammered. I was nervous that she was going to slap me for keeping her husband hostage on a psychiatric hold without any right. I could kiss you, she finally said. Excuse me? Whatever you said to him really did something in that brain of his. He's been talking about offing himself if this was cancer for weeks. Now he's talking about wanting to fight this thing to the end. It was a bit surprising. I couldn't think of anything I said to him that would have made that difference. I think maybe he just needed someone to be in it with him for a bit when things were really bad. I was glad I could do that for Charlie. Me too, thank you. We got off the elevator together and walked back to Charlie's room. He was sitting up in a chair, sipping coffee and reading a paper. I sat down with him, and he told me about the box score from the Red Sox game the night before. Can't believe I missed this game, he said, shaking his head. He looked up at me. You look exhausted, kid. Are you free to go home yet or what? I nodded. Then get out of here already. I shook his hand and walked out the door. As was true for many consults, I left without knowing if I would ever see the patient again. I wondered how it would all turn out for him and hoped for the very best. So I'm going to pause there. That's the end of the chapter. And now what I'd like to do is talk to you about the context of how this book came to be, remembering that Charlie and my encounter with Charlie takes place about 10 years ago. In my own life, I've always liked to write. I think I say in the book that if I knew I could have made it as a screenwriter, I probably wouldn't have become a doctor. but I wanted to be a doctor. I wanted I couldn't sort of turn off the scientific part of my mind. And I knew that being a doctor was a more sort of straightforward path toward doing good in the world, hopefully, and also potentially, hopefully living a comfortable life. I had seen it in my father. And so I just sort of continued down that road thinking, well, I can write as a hobby. I can write little things here and there. I submitted stories to literary medical journals during med school, that kind of thing. But as I sort of grew up and I finished residency and I started as faculty, I really focused more of my energies on academic work and time with my family and things like that. And my life had taken a certain shape by about 2018. It was a very um, sort of in medicine, when we say something's unremarkable, we say it in a positive light, that the labs were unremarkable, that CT scan or MRI was unremarkable. It means it was good and normal and we don't have to worry. So in 2018, my life was quite unremarkable in that sense. I was married, we had a baby, had just moved out to the suburbs. I had a nice faculty position, had just been promoted recently. And in January of 2018, a series of events transpired very quickly. First thing was that I noticed I was losing weight without meaning to, which was very unusual. And then second thing was that I was having night sweats. I was waking up really sort of drenched in sweat. Didn't really think anything of it. We had gotten new bedding, and I thought, well, I just must be hot. And it's only in hindsight that those two things together are so obviously associated with what would turn out for me to be a kidney cancer diagnosis. So it was January 17th when I had something called gross hematuria, which is a technical term for having red urine, essentially. It's a term that sounds as bad as it is. So that prompted me to see the doctor the next day, which prompted me to get a CT scan the day after that. My labs were all way off. My wife and I were sitting up watching the labs come in overnight, thinking with our medical hats on, what could this be? It can't be anything good. Something terrible is happening. And then the scan was the next day on the 19th. And that's when it was a Friday afternoon and I knew I couldn't wait all weekend to wait for the results. So I went to the medical imaging department. I got the image on a disc and I went to my own hospital. I tried to find a radiologist who might read it for me unofficially, but there was no one there. It was already pretty late by that point. So I just put the disc in myself, and anyone, not a doctor, and if a psychiatrist can say it, it can be true for anyone. I saw this gigantic mass on my left kidney, and I knew pretty immediately like what was going on. And so at that moment, your life sort of explodes. And only in hindsight, when thinking about my interaction with Charlie, did I think about how he might have been feeling in that moment, that you think you're on one path and you're in denial of the warning signs that might be going on about everything else. And then when it becomes real, when you get the diagnosis, suddenly you're faced with this task that you have to push through, which is, okay, that image I had of what the rest of my life would look like is not available to me. What's available to me is unknown and really quite scary. And so, immediately what a lot of patients do is they start Googling survival rates, and I was no different. And when I was diagnosed, at that point, most of the reputable sources online were saying that 5-year survival for stage 4 kidney cancer, if it was located beyond the kidney in the lungs, for example, or lymph nodes, distant lymph nodes, which it did turn out eventually to be for me, that was a 8% 5-year survival rate. And that's a terrifying thing to be faced with suddenly to read on your computer screen, just like Charlie was looking at that idea as a death sentence, or suddenly you're sort of your whole world is just really flipped upside down. Now I had such a strange experience with my diagnosis because I was a doctor and I saw the system with all of its flaws up close. And then I got to see it again with all of its flaws as a patient. I saw both the wonders of modern medicine and the drawbacks. And that's because um, you know, modern medicine has so many wonderful things to offer, so much so that in here we are in the year 2021. This is almost 4 years from my diagnosis, and in that time, especially in the first couple of years, I went through 5 different procedures, surgeries, frankly, and 2 different immunotherapies, actually 3 different immunotherapies, and some of them were really pretty intense. I've had one kidney entirely out, another one half frozen to death, one lung partially removed, and the other one again cryoablated, which means basically pretty intensely um, uh, injured intentionally in the area where the cancer is. So I've been through a lot, and yet the last 2 years I've been remarkably healthy. The last scans that I had just in August, 2 months ago, they were clean as can be. So the future is very much unknown, and the standards of care for cancer right now are totally different than when I was even first diagnosed a few years ago. So this idea, something that it's taken me a few years to learn, and I think some of it comes through in Charlie's story, the idea that going forward with the uncertainty looming over you, you don't know how your path is going to go. And at a larger level, that's true for everyone here, everyone who's listening to my voice right now, and everyone who's not listening to my voice. The path forward for all of us is unknown. None of us know when we're going to die or how we're going to die or exactly what the path leads to. But the idea of going forward, making the best choices you can with the information you have, and trying to enjoy and feel fulfilled within your life by making choices that fulfill you, that align with your values, that's something that took me. It's almost like a cliche, but it took me to the brink of this, of looking a stone's throw away from my own death, to realize that that distance between where I am and death can be filled with all kinds of dread and anxiety, but it can also be filled with all kinds of wonderful things. So I started writing about my experience. It brought me back to that sort of early primitive eagerness I had to write about what I was going through, to process my experience. And the things that I was writing suddenly, at that intersection of being a doctor and a patient, they allowed me to get essays placed in NPR's websites, and the New York Times and the Boston Globe did a feature about this psychiatrist who's opening up about his own health and how that impacts his practice and all those things. And it eventually led to the literary agent, who reached out to me and asked if I had any interest in writing a book. And that led to this whole journey about, this book that I never in a million years would have predicted would have been possible, or even, doing an event like this, talking to you. Never would I have imagined it right before the diagnosis as even a possibility. And so I think there's a terrible and beautiful serendipity that we all engage with, that has changed my perspective of how I live my life. I wish I could convey it to people. I don't think that I really can, except by doing what I'm doing. And I think I probably still fall short in being able to convince people that there is this path whereby you can live more fully by making choices that you really want to make, as opposed to choices that the inertia of your momentum just sort of carries you forward. I think so many of us do that without realizing it. We just do the next thing and the next thing and the next thing because it's asked of us, because it's what we're sort of expected to do. So, so with that, I think that what I'd like to do now is get back into the book and sort of tell you how Charlie's story ends. It will spoil Charlie's storyline a little bit for those of you who haven't read the book yet, but I think it's worthwhile. So, what I'm going to do now is pick it up much further along in the book. This is in the chapter called Being Present, which is chapter 29. It's about midway through. It's page 248. Our residency overnight call schedule also lightened up in our third year, so I picked up the slack and began moonlighting almost every week. Moonlighting means working outside the hospital. The gig became easier with each attempt. Rachel and I still weren't public about our relationship, but I had never felt this way before. I'd been in love, but never at a time that was reasonable and appropriate to consider marriage. I was entertaining the notion that she was the woman I wanted to spend my life with, and if there was even a chance of this, I needed to start saving up for a ring. I would wonder if I was delusional. After all, she hadn't even told our closest friends about us. I still suspected that she was ashamed of being with me, but then on some quiet nights, long after we should have fallen asleep, I would stroke her palm while she waxed poetic about what we would name our first child. Despite the very real possibility she'd be moving across the country in the next year, I wanted to start saving up for an engagement ring, and moonlighting was the only way to do that. I was on one of these per diem shifts at a nearby community hospital when I shared the elevator with someone who looked familiar. She was a late middle-aged woman, and she was squinting at me, presumably trying as hard as I was to figure out how we knew each other. Several seconds passed. "You're the hospital shrink." "Hmm? You're the kid shrink who saw my husband after he came out of surgery." I smiled. "You're Charlie's wife." It had been months since his diagnosis. I was glad to be reminded of him. "How are you both doing?" "Well, we're here," she said, motioning to our surroundings in the emergency department. "He needs to get that belly drained again." I nodded, knowing that liver cancer can leak malignant fluid into the abdomen in the later stages of the disease. "He'd love to see you. We're in Bay 18. Come." "I really shouldn't, but please give him my best." "Come," she repeated more firmly. She took me by the hand as the elevator door opened and led me straight to her husband's tiny curtained area of the emergency department. "Look who I found," she said, enthusiastically, pulling the curtain back. A team of 2 clinicians were all gowned up from head to toe, together guiding a gigantic needle straight into his protuberant belly. The man on the receiving end bore almost no resemblance to Charlie I had met months earlier. For a moment, I wondered if I had embarrassingly conflated 2 different patients named Charlie in my memory. "Hey, don't you knock," he shouted back. It was only after his response that I saw the man I knew. His skin was stretched around the belly but hung loose over his joints, arms, and face. His eyes and skin had a yellow hue, and the paper-thin skin around his eyes and nose were infiltrated by dozens of tiny black veins. But under it all was Charlie. "Look, Charlie, look who I have here," she said, motioning to me again. "Son of a gun, the shrink's apprentice," he shouted, now with the needle halfway into his enormous gut. "How the hell are you, kid?" "Oh, I'm fine. You look good," he said, as the clear yellow fluid began to filter out of the giant needle. "You've even got a little psychiatrist beard now." "Yeah, took a while for that one to grow in properly." "I haven't fared as well." I could tell he wanted me to pull up a chair, but I had work to do that was piling up every minute I spent chatting. "Charlie, come sit. Distract me from this fucking thing," he said, motioning to his deflating belly. "That's a lot of fluid," I said. "This ain't nothing. The over-under on this is what, 17 pounds, I think? Last time my belly was twice as big and they had to get a second container to hold it all. 27 pounds. Guy wouldn't tell me if it was a record, the prick." "You holding up okay?" I asked. I already knew how he was holding up. His body was breaking down day after day, and he didn't have much time left. His mind was doing whatever it could just to keep the dark thoughts away. "You know, kid, it's been a real shitstorm since we last talked. Honest to goodness, I wouldn't wish it on anybody." He paused to consider his next thoughts. "I'm glad I didn't off myself, though. That wouldn't have been right." "I'm glad too," I said. It was the kind of straightforward, plainly honest reply I would have been embarrassed by in my earlier years as a resident. I would have thought that a real psychiatrist should have something more clever to say. I'd learned, though, that a short and true response, raw as it may be, always landed better with patients than whatever my impression of what a guy from Harvard would say. "Maybe it'll all be worth it, you know. My doc is getting me lined up for a clinical trial. Some experimental drug. Could be a miracle. Who knows?" "I hope so," I replied. "Charlie, you gotta go. I know. It's okay. Go. I'm going to come back again after I've cleared the board. We'll have more time to talk." He smiled. "It may be a while. I'm a few patients behind already." He waved me off. See ya, kid. I left feeling guilty, but not knowing what I could have done differently. I was being paid to work. I had to do it, and there was a lot of it. I saw a patient with mania, a teenager who'd run away from home was brought in by police. I evaluated 2 suicidal patients and 2 men my age who were coming down from bad trips on PCP, violent and raging at me. By the time I was caught up, I was physically and emotionally spent. The sun was rising, and I put one foot in front of the other until I arrived back at Bay 18, only to find the custodian mopping up the floor. I walked back to the makeshift office for Moonlighters and plugged into the online census. Charlie had been discharged home 3.5 hours earlier. Damn. It was 4 months later that I spotted Charlie's name on the board back at my own hospital. He was admitted to the oncology unit, but he had been marked for transition to palliative care. I was working on the psychiatry consult service, and I had no business visiting him, but I needed to see him. Having left him to go do other work hadn't felt right at the end of our last encounter. I arrived up at the unit and navigated to the room with his name posted outside the door. I was taken aback as I entered to find an emaciated man with tubes coming out of his nose and chest. His eyes were open, but they wandered constantly, without any purpose. I approached him, but I couldn't seem to engage. I couldn't make contact. "Hello, Charlie," I finally said. There was no acknowledgement from him. His eyes continued to dart without any clear rhythm or purpose. "It's Adam Stern. I don't know if you can hear me or understand me." I looked up at the whiteboard to his left to begin to put some of the clinical bits of information together to form a picture. He had developed metastases in his brain. They were causing swelling that pressed on his brain stem. There had been no miracle for Charlie in the next experimental drug. "I just came by to see you." I paused, waiting for an epiphany that did not come. The sounds of the medical devices chiming were distracting and irritating. I took his limp hand in mine and felt a slight grip take hold. It may have only been a reflex. "I want to say that I'm sorry." I waited, but there was nothing reflected back to me. "I'll let you rest." There was nothing left to say. I let go of his hand and placed it gently at his side. I have no idea what compelled me, but I left a little note on the whiteboard next to his bed. "Here with you," signed A.S. When I saw Charlie's name drop off the census, I headed back to the room in search of some form of closure. The bed was empty and cleaned. There were no more chimes from the machinery. It wouldn't be long before the next patient took his place, but I did see that my note was still there. It was with him until the end. So that's Charlie's story. And, clearly I see a bit of myself in Charlie. I can remember being with Charlie in those moments and what I felt. And I can also now, under my current circumstances, I can appreciate some of what Charlie was probably feeling with the sense of impending doom, but a sort of uncertainty around it. And, what I titled this talk, this engagement and with Fox Cities Book Festival is committing and moving forward no matter what. And when I was diagnosed, something that I found that I often did with family members, with friends, was I would end emails without really meaning to, without really thinking much about it. If I needed to convey what was going on, a treatment update, a surgery, a recovery email, just letting you know I'm doing okay, I would end the emails by saying something along the lines of, we go forward together, essentially. And there was something so simple, but something so important, and to some degree, I thought powerful in that sentiment. And I've tried to hold on to that. And just by going forward, making choices that I want to make that are aligned with how I want to live my life, it doesn't change the outcome. It doesn't change whatever may be in the road ahead for me or anyone else for that matter. But it does let me live a life that I'm proud of, that I'm excited about, that fulfills me. And it lets me do really interesting things like write this book and talk to you about it. And why don't I pause there and see if Megan or Kirk can open it up for questions. I'd be delighted to answer any.
Great, thank you so much. So yes, for participants, you can use the chat feature, the question and answer box to type in any questions you have for Dr. Stern. And also if you're watching on Facebook, feel free to type those in. We're watching those comments coming through as well. So grab some here. This one. Well, I'll start. I have a question for you. Thank you so much for that presentation. It was wonderful. I was wondering too, I had read an article that you used to write when you were younger for like a literary journal. Have you always been interested in writing?
Thank you, Megan. Yeah, I can say with confidence, I was always interested in writing. In fact, my parents, thankfully, are healthy and well in their 70s and early 70s. If they're out there listening, I want to make sure everyone knows they're vibrant in their early 70s. But they've recently been sort of cleaning out. They wanted to paint my old childhood bedroom, and they've been cleaning out the shelves and the cabinets and all this stuff. And I've actually found some journals from like when I was in the second grade, and there's some stuff in there they're 3-4 sentences long, but they're stories. They're stories about fighting off aliens, and there's a story about a dolphin species that became hyper intelligent and wanted to take over the world. And so reading this stuff is amazing, just because there's a thread there that I could follow directly, almost, from where it was when I was 7 to now. The format and the form has changed somewhat dramatically, but I always like to write. And then, again, in college, I thought, oh man, maybe I can sell a screenplay. Maybe I could be like a movie writer, something like that. And then I decided to go to medical school and become a doctor and just treat writing as a hobby. And in medical schools, that's when I would submit to these medical literary journals, some really good ones around the country. And I just loved doing this sort of creative nonfiction or even fiction about medicine. I think as doctors, we have this privilege to have access to people and their stories and their characters, and conveying the humanity of medicine. I actually think is an important job. It's one that I take seriously because it we have again this privilege of taking care of people when they are vulnerable and wanting to help them, and showing the humanity of both the patients and the healthcare providers, the doctors, nurses, everyone, social workers, everyone that comes into contact with patients. I think is an important job. um, we can lose sight of it when we just read about, the insurance payment models and the finances of medicine and all of that. And so, to anyone listening out there, or anyone who knows someone who's interested in either mental health care or healthcare, it's a stressful field, but it's a wonderful field. And I'm living proof, you do not have to shut off that part of your brain that's interested in creative things, that's interested in humanistic things, to be a doctor. So, thank you for that question.
Okay, thank you. And we do have some coming through. So we've got one from Jan. So Jan says, great job. Did you participate in things like meditation during your healing journey?
Absolutely. Great question. I have tried several times to pick up meditation. I recommend meditation to a lot of patients that I work with, because mindfulness, the idea of actively pursuing mindfulness, it has clinically demonstrable benefits. It has, clearly mental health benefits, but also physical benefits, lowering blood pressure naturally, stress tolerance. I think meditation is the most wonderful thing. I've struggled with it. I'm not very good at it myself. And it's a skill that I still aspire to getting back to, and trying to get better at. One thing that I have adopted successfully is the idea of practicing gratitude. That's something that's sort of a cousin, I think, of meditation. It's the idea of pausing every day to give thanks to yourself. Or in my case, I write it in a little notebook because that's my nature, is to try to put it from my mind onto paper. Um, just taking note of things that are going well or that you appreciate about your life in that moment or about the world. It's something that is so simple that I can do. It takes just a few moments at the end of a day for, in most cases for me. And I find that just doing that has helped me look at the world in a more positive light and has changed my overall outlook. But someday I hope to really be a master at meditating, but I'm not there yet.
And yeah, I always want to do that as well. It's hard to shut your brain off. Okay, so for Denise, we've got a question from Denise. She asks, have you changed the way to practice medicine because of your experiences? And then she also said, I am so touched by your presentation.
Thank you very much, Denise. I appreciate that. I have changed the way I practice. There's no question, not intentionally. Um, there are two ways that I can think of off the top of my head. One stems from, the piece that I got into the New England Journal of Medicine was about whether or not my diagnosis makes me more empathic or less empathic as a psychiatrist. And I think at the end of the day, it makes me more empathic. So I may have less patience for trivialities of medicine and things like, um, the logistical, challenges of seeing a doctor and co-payments and this and that. Those things I have less patience for. But the connection with the person on the other side of the room, I think I'm actually more able to emotionally put myself in someone's shoes because I've now had a greater experience within hardship. I lived a very privileged life for most of my life. And I think I can appreciate someone who is living with an invisible illness, like a mental health disorder, where it's not outwardly obvious. I think most of you who might be looking at me right now probably say, oh, he doesn't look really actively sick. And that's a blessing and a curse. It's a blessing because it's wonderful to be healthy looking. I think I am. I don't mean to presume, but it's a curse only in the sense that nobody knows how many scars are underneath my clothing. Nobody knows the trauma that my body has been through. So, except the people who are let in on that. So I hope that I'm more empathic with patients. And then the other way is again, I think previously I used to worry a lot about dotting every I, crossing every T in a way that would prevent me from getting into trouble with the institution or my boss, or my boss meaning like the director of the department or what have you. And if he's listening, I do cross every T and dot every I. But I care less about that stuff now because I really try to do what one of my mentors here, a guy named Dan Press at Beth Israel, early on, before I was ever sick, tried to convey, if you just do what's right for the patient, if you just put yourself in the patient's shoes and do what you think is best for them, you can never go wrong, even if it's not in keeping with whatever protocol is designed for that patient at that moment. And so I've been much more able to do that without fear of some sort of logistical repercussion. And I think those both are changes for the better. Thank you again, Denise.
Thank you. Okay, we also have one here from Margaret. So Margaret's question is, she says, as a friend of 4 different cancer patients now, what are some things I can do or say to show them I care about what they are experiencing?
Thank you, Margaret. That's a wonderful question. I can't speak for everyone in terms of where their sensitivities may lie. Some people find certain phrases, certain language offensive, and for some people it doesn't bother them at all. And for me personally, I've come to a couple of different conclusions. One, it kind of irritates me if someone says, "How you doing?" but they don't really care what the answer is. So I've tried to actually stop doing that myself. I used to do that as much as anyone. "Oh, hey, how you doing?" and keep walking, right? If you're in the hallway, you're passing someone, you're not actually saying that you care, that you want to know how they're doing, or you do, but you don't have time to listen. So when I'm in those situations, I try to actually say something like, "Oh, it's good to see you," if I'm not actually going to stop and listen to how someone's actually really doing. But I really love it when people do really care how I'm doing, and vice versa, and stop and have that conversation. So that's one note I've made. The other thing is, I love it when people tell me I look good or I look well. That's a wonderful thing to hear. I do not like it when someone says, "Oh, you don't even look sick." That really irks me. So being mindful of how those kinds of comments are being received is always a good thing, I think. Um, there's a lot of stuff like that that people don't really think about until you're on the other side of a diagnosis like this. One of them is unsolicited advice, or, "Oh, I had a cousin with that. My cousin's neighbor had a kidney cancer, I think, and she died," or, things like that are not helpful at all. But um, empathizing with someone's position is always helpful. So saying, "I can only imagine how difficult this might be," or, I'm available to you anytime you want to talk about what your experience is like. That kind of thing is helpful. Um, so those are some, off the top of my head, those are some basics about how to relate to people with cancer. The last one I'll say is that it's a very hard question to answer. If you say to someone living with disease, "Well, just is there anything I can do for you?" Usually it's a hard thing for someone to answer. "Yeah, can you give me a lift to the hospital on this date," or what have you. But just doing a nice deed or a good gesture for someone is something without, it doesn't put the weight of the good deed on the person receiving it. So if you know someone and you know what they like, just doing a nice thing for them, sending when after I had my kidney out and I was sort of sidelined for a while, we had like a meal train where friends were able to send us dinners on a schedule, and it was like really nice because we didn't have to think about it. We didn't have to like organize it ourselves or do it. So that kind of thing, I think you can apply broadly to people who are dealing with any kind of really severe stressor in their life. Thank you for that question.
Okay, thank you. And then we have another question from Jan. So she was wondering, her comment was that addictions seem to be a major issue in the world for people to escape and cope. What thoughts do you have for helping addicts based on your professional experiences?
Thank you, Jan. Yeah, addiction is such an incredibly difficult issue. It's something that we're gaining better understanding of in terms of the neurophysiologic basis for why some people are more predisposed to become addicted to substances, and some are less predisposed. We are just beginning to scratch the surface, I think, of really good treatment options, things that will help people, either reduce their use or eliminate their use. There are a lot of, I'm talking about it from like a biological standpoint. There are some medications that can be helpful. There are some within psychiatry, there is a corner of psychiatry and primary care that is aimed at helping addiction. So I'm certainly far from an addiction specialist, but I know there are entire sort of communities that are aimed at helping people who are struggling with this. And I do think it is a useful premise to think about it as a brain disorder, because it's both a combination. In other words, it is a person's responsibility to commit to trying to live a better life and not live a life that is dependent upon a substance. But on the other hand, it's also, they can't necessarily do it, but in most cases, people have a very difficult time achieving remission from substance use disorders without help from professionals or without help from a community like an AA community or NA community. Sometimes that community can take the shape of spiritual organizations, religious groups, if that's something that people are invested in. Sometimes it can be a non-medical community that's just a group of people. Sometimes it can be a sort of detox and rehab community that is, not within medicine, but not entirely disconnected from medicine. So there's no one right recipe. And I will say there's still a long way for us to go before we really have a good handle on how to treat substance use disorders, to get people, even I was about to say sober, but even not necessarily sober, but not at a point where their lives are at risk or their quality of life is at risk. So there's still a long way to go, but I think we are making strides in recent years. The more we understand how things dysfunction in substance abuse disorders at the neurologic level, the more we'll be able to potentially treat these things in a more efficacious way. So I am hopeful for the future. Thank you for that question.
Thank you so much. So we're just about hitting an hour here. Thank you so much for such a wonderful presentation. I will say we do have another question from Denise, just asking if you have a website, which I will, I believe it's linked on our book festival page. If not, I will make sure it's on there. And then also she was wondering if, are we able to find some of your journal articles? I know there's quite a few articles that have really great interviews with you. So, but yeah, we just really appreciate your time. So if you let us know.
Thank you so much. Yeah, I have a personal website. It's just my name, md.com. So adamsternmd.com. And if you Google my name, Adam Stern MD, it should show up pretty quickly. And it has a little section probably about the book, but it has then all these essays I've written and then all the scholarly, if you're interested in my work in academia, it has all those articles. So feel free to check it out. Thank you so much for everyone for your attention. This was really lovely, and it's a privilege for me to be able to do events like this. So thank you for the invitation. I really mean it.
Great. Yeah, thank you so much. We really appreciate your participation. It was a fantastic time speaking with you and learning more about your experience. So, and thank you so much everyone for joining us. Make sure to keep attending. We've got a couple, I think, yeah, actually more than a couple events coming up this week. And you'll see in your chat feature here, there is a link to our website for a donation and also to fill out a survey because we want to hear more from you and about what type of events you'd like to see in the future. But thank you so much, Dr. Stern. This was wonderful.
Thank you.
Yep. Thank you so much, everybody. Have a great day. Thank you.